Welcome. We are speaking with Dr. Paul Hasselback, who is Medical Health Officer for Central Vancouver Island. Welcome.
Thank you very much.
Dr. Hasselback, please tell us what role do health authorities and other health organizations play in reducing the public health burden of air pollution?
Well, I think if we're looking specifically at British Columbia, if we look at who actually is doing a lot of this work, I actually went around and asked the health authorities, what are you doing? Where are you involved? And there's a little bit within the regional health authorities where there's often one person who's designated as the air quality person, and often a medical health officer who has air quality as part of their environmental portfolio. And both of them are probably spending maybe 10% of their time. So reality is it's not a lot of time being dedicated within the regional health authorities. We have a variety of air quality management tables that exist, but relatively speaking, it's come and gone over the years. They seem to form over certain issues, get their business done, make a change, make a benefit, and then they don't seem to be sustained. And so what we're seeing is a low level of input, but a fairly high yield coming back. And I think that's one of the key public health issues, that it doesn't take an awful lot here to make a huge difference. On the converse side, or about an equal amount of time is being dedicated at a provincial level for the public health side. Okay, and that's quite specifically our colleagues at the BC Centre for Disease Control, some within the ministries who are public health professionals spend some time working on this, and it's about an equal amount. But if you actually look at the overall amount of resource that we spend on air quality, it's relatively low, but probably has made a huge difference over the years.
Interesting. Okay. Are current air quality management practices protecting everyone equally? And if not, what do you think can be done to reduce those inequities?
Equity is going to be the big issue in air quality as far as I can see it looking forward. Truly what we're getting is where the degradation is occurring in air quality is not where the benefit is accrued by those that potentially get that resource from it. And the best example here is when we're looking at the oil and gas industry, resource extraction industries, where oftentimes they're fairly rural environments, perhaps smaller communities. Pulp and paper would be another one that historically has been in the valleys and high levels of poor air quality, but that the products are exported into larger urban settings. So those rural communities are truly carrying an inequitable amount of burden of the exposures here. Okay. I think we're also getting into other issues, and we're beginning to explore this. There's a socioeconomic gradient. Well, we often locate poor or less affluent housing in settings that have poor air quality, whether that's adjacent to railroads, industrial parks, and we end up exposing those that are actually already at the highest risk to the poorest air environments as well. We're going to see an age change that's occurring, and how we already know that those that are a little bit older are at higher risk. As that age population increases as well, they'll be carrying the greatest burden. So if we start talking about equity and inequitable exposures here, I think that that's one of the major public health issues that are going to be grappled with, because we all breathe the air, and we're often putting people into settings where they have no choice, and when they have no choice, that truly is an inequity.
What do you think can be done to address some of those inequities then?
Well, I think first of all, recognizing it. Second, measuring it. And third, then start having the conversation about what are the policy issues here. what is fairness here? I don't want in any way to suggest that we shouldn't have economic development occurring. Okay, but if we compromise that economic development, that burden may be carried by a different population in terms of lack of access to fuels for automobiles, as an example, or transportation in major urban settings, because we're compromising the growth of the energy sector in rural areas that are going to be the inequitable carriers of poor air quality. So we're not having the value conversation that's necessary about what are we willing to give up so that others can benefit, and we're not compensating those that are feeling that inequity in any fashion. And I'm not going to say that's a monetary compensation, but we often are making these policy choices without recognizing what those impacts are or hoping in some fashion that it's such a small minority that they're not going to raise their voices. And I think what we have seen lately is a lot more of those voices being raised, whether that's our First Nations communities that truly are expressing how they are carrying or losing their connection to the land, okay, and in this case the air that goes with the land, but also our rural communities in particular. And I think we're also going to start seeing that more in some of the urban settings where people living in proximity to industrial areas, living in proximity to major transportation corridors, railroad corridors. We've seen it with some of the marine ports. People like their waterfronts, and idling ships do produce poor air quality. There's one where that voice is starting to speak up. Not necessarily the highest risk group, but it is one that is getting exposed in a different fashion.
New dimension to a complicated problem. In your experience, Doctor, what are the biggest challenges or barriers to the integration of public health into air quality management, and how do you think we can overcome these barriers?
Well, there's lots of issues when we start talking about public health or health impacts of air quality, the atmospheric science and the policy development. And there's perhaps no area that I can think of that is more affected by the politics and the political environment. And certainly at this day and age, we're seeing other jurisdictions where changes in the political environment are going to have a negative impact on air quality. Potentially changes could have a positive impact as well, and we might actually be seeing that in BC. It's tough to say that at this point. Those are early days. Public health is being consistently in the background, often at the table, but not necessarily a driver. We've seen real advances in the atmospheric science. We actually haven't seen that comparable advance happening in the measurement of the health impacts. And I think that the science of monitoring is exceeding the science of what those negative impacts are. That's going to be an issue that we're going to have to grapple with when it comes to that third portion of the sort of stool here, the three-legged stool, which is the policy development. Policy development is being driven often by the monitoring and numbers, modeling, those sorts of things, and essentially is going to need to be driven by health in the future. So public health has to be at the table and has to be active.
Good points. Can you provide any examples of successful air quality management initiatives that benefited from the involvement of public health professionals?
I think there's lots of examples here. And historically, if we go back, we're really only looking at about 5 decades of understanding that poor air quality is going to result in a health impact. So what have we achieved in 5 decades is an astronomical improvement in general air quality. Not always appreciated, because we're often thinking of what was the air quality like last year or the year before rather than over those decade periods of time. But we've made huge benefits, and a lot of that's actually being driven in part by an understanding that poor air quality results in very poor health outcomes. So at a policy level, health has helped drive some of that, but it's often not the major driver, but it's definitely been there. And ultimately, it's very tough for policy people to make a choice that actually is going to put others at risk and are encouraged to make choices that reduce that risk. If we're looking in the BC context, I think we've seen some real benefits in the Metro Vancouver area, Lower Fraser Basin air quality management. There have been incinerators that are being proposed that didn't go forward. I think we've seen some cleanup in terms of emissions, reductions in emissions. We saw the phasing out of beehive burners. Okay, there's just a prime example where a well-known polluter, but a point source polluter, was phased out because of the poor air quality. I think that we've seen other situations where quality management groups have come together and often addressed issues. Central Okanagan's a prime example. I think that we've seen some other places, and I certainly am familiar with the island, where groups have come together and sort of said, hey, we don't like these advisories, we don't like the poor air, what can we do about it? Implement some of the important changes. For the Central Okanagan, that was about when agricultural burning could or could not occur. Putting in chipping programs. Health was always at the table, not always the major driver, but was always at the table, and facilitating some of that change. So those are just some examples. Trail would be another one where a significant point source emitter was involved, where health was a major driver in reducing general emissions in that particular community, and that's been to the benefit of the trail community.
Thank you for those examples. What do you see as the most pressing issues in air quality management currently and in the coming decade for both urban and non-urban areas?
I think there's a variety of issues that are coming forward. I think equity really is a major issue, and some of those equitable issues are going to be a real policy challenge. I think that we have some science questions, particularly on what those health impacts are. It often takes decades, literally decades, before we improve our data collection. So we can look back to the 50s, 60s, 70s. We were measuring total suspended particulates. Then we moved to particulate matter 10 microns, and then 2.5, and now we know it's the less than 0.1 may be a major contributor. That's still up in the air, but we don't have a monitoring system, and we don't have personalized measurements that actually will allude to what that's look like from a health impact. I think we're going to get more information on the small area variations that exist. While we're getting really good about measuring those variations in poor air quality by mobile monitoring units, we actually don't correlate that very well with what those health impacts are. If we can learn more about what small area variations actually have from a health impact perspective and individual exposures, that I think will be one of the major driving factors for policy development going forward. I think another area has been the historical emphasis on individual pollutants. And that stems back to historically how we got to where we are today. A fair bit of work, particularly in the Canadian context, and I think Canadians should be taking a fair bit of pride in this, is a recognition that it's the mixture that actually makes the difference. And so the multi-pollutant environment and being able to do monitoring that actually looks at that and predicts what those health outcomes led to a better communications tool. But I think will also be one of the big science issues for the future, that it's not about criterion pollutants or individual pollutants. It's about the mixture and what does that look like. it probably is better to be living in certain non-urban communities. But those non-urban communities often are the ones getting advisories because they have specific days when things get bad. But better to live there than perhaps in a large urban environment where the multi-pollutants are a more consistent exposure component. So those are just some of the issues that I think are going to be key ones. I think the final one on this one is it increasingly becomes difficult to make policy changes. We don't have a policy environment that facilitates change readily any longer. It's not going to take months to set a new criterion or maybe a couple of years. Oftentimes it takes years and years before people are willing to even consider that there might be a benefit to be changed. And we have this conflict that exists between those who are going to benefit often on an economic basis, but not just on an economic basis, but and those that are going to be harmed by whatever changes occur. And those conflicts that exist and management of those conflicts, we do not have a good structural basis in place to have resolution there. And our pipeline debates, I think, are a prime example of that right now.
Mm-hmm. All right, we're out of time, but
Okay.
thank you for spending this time with us, Dr.
It's been
Hasselbeck.
absolute pleasure. Thanks very much.